All right, so this is Sadie Barnett tuning in to do my final anatomy project. I have chosen to do a podcast today discussing the Achilles tendon, specifically the rupture and repair journey that goes along with it. Like I said, this is for my anatomy class, so bear with me if it gets anatomical. So a little intro or background as to why I chose this topic. I recently tore my own Achilles tendon 4 weeks ago, and it's just led me down this journey of wanting to understand the more detailed concepts behind what exactly the Achilles tendon is, why did it rupture, are there risk factors that increase that likelihood, and how does it repair itself? So how did I tear my Achilles tendon? Well, I was playing basketball and, it crossed this chick up, the crossover cut to the rim, and the power output with my foot just snapped it right in half. It's terrible. So first of all, I'm going to start with the Achilles tendon is located at the back of your lower leg. It's a tendon that is made up of dense connective tissue that anchors a muscle to bone. So specifically, it connects your calf muscles, the gastrocnemius and the soleus, to the heel bone, which is the calcaneus. It runs down from the lower part of the calf behind your ankle and inserts into the back surface of the calcaneus or your heel bone. The Achilles tendon attaches directly into the periosteum of the calcaneus and also into the bone itself. The periosteum is just an outer layer surrounding the bone. It's a fibrous membrane that has blood vessels and nerve endings. So that's where your Achilles tendon attaches into your heel bone. So at the insertion site of your Achilles tendon is the posterior surface of the calcaneus. The fibers merge with the periosteum and anchor into the underlying bone. So the transition is a fibrocartilaginous enthys, specifically meaning the tendon fibers gradually blend into the cartilage and then the bone. So basically, this structure helps distribute the mechanical stress when the powerful calf muscle contracts during walking, running, or jumping. And the Achilles tendon is the thickest and strongest tendon in the human body. So it's built to handle really massive forces generated when you run, jump, or push off with your foot. Okay, so next we're going to talk about the anatomy of the tendon. So the structure, the composition, the collagen fibers, blood supply, and nerve innervation. The Achilles tendon is made up of dense, regular connective tissue that's engulfed in a tendon sheath. So a tendon sheath is connective tissue that surrounds a tendon at places where the tendon crosses a joint. It contains a lubricating fluid to help prevent friction and allow smooth movements of the tendon. So what is dense, regular connective tissue? It's primarily composed of collagen fibers, specifically type 1 collagen, which provides the tensile strength. Collagen fiber is made from fibrous protein subunits linked together to form a long and straight fiber. So collagen fibers, they are flexible, they have great tensile strength, they resist stretching, they give ligaments and tendons their characteristic resilience and strength. They hold connective tissues together even during movements of the body. So the Achilles tendon is made up mostly of type 1 collagen fiber, which is a category of dense regular connective tissue. This tendon specifically is arranged in parallel bundles, so it can withstand great tensile stress in one direction, which is ideal for transmitting the force from muscle to bone. The Achilles tendon, though, is actually relatively low in blood supply, which contributes to the slower healing process after you have an injury to the Achilles tendon. The blood supply for it comes mostly from 3 sources. the posterior tibial artery, the fibular artery, and the musculotendinous and osteotendinous junctions. The main blood supplier for the Achilles tendon is the posterior tibial artery. It basically just sends small branches directly to the tendon, especially near the muscle tendon junction and the lower tendon near the heel. Another source of blood flow is the fibular artery, and this just kind of provides like some additional like smaller branches of blood flow. And then, like I said, you've got the musculotendinous and the osteotendinous junctions, which also comes from where the tendon connects the calf to the bone. So the middle part of the Achilles tendon, approximately 2 to 6 centimeters above the calcaneus heel bone, is the worst vascularized part of the Achilles tendon. It's considered poorly vascularized. So that's why that's the most common area for the Achilles tendon to rupture, kind of like right in the middle. Next, we've got the nerve innervation. So the Achilles tendon itself is primarily innervated by sensory branches from the sural nerve. The sural nerve provides sensory innervation to the skin and the tissues around the Achilles tendon. So you can sense pain, touch, proprioception, which is body position awareness, around the tendon area. And then you've also got like the motor control of the muscles connected to the Achilles. Like I said, the gastrocnemius and the soleus, which is the two muscles that make up your calf muscle. And that motor control from the nervous system comes from the tibial nerve. These are the muscles and the motor control fibers that generate the force that pulls on the tendon. There may also be contributions from like small branches of the tibial nerve. But basically the main innervation is the sural nerve, which is sensation, and the tibial nerve, which is muscle control. And then we've already kind of touched on this, the motor innervation, the muscles that act on the Achilles tendon, the gastrocnemius and the soleus, which make up your calf muscles. All right, and our next topic is going to be the function of the Achilles tendon. It plays a pretty big role in pretty much all of the powerful lower body movements that you do. So breaking that down a little bit, you've got plantar flexion, which is the bottom of your foot. The Achilles tendon transmits force from the gastrocnemius and the soleus muscles to your heel, which allows you to point your toes downward, and that's called plantar flexion. And this is important for pushing off the ground for that power output, especially like in athletics or like powerlifting, Olympic lifting, walking. Next one is walking. During walking, your Achilles tendon stores energy when your heel lifts off the ground, and it helps you push your foot forward with the next step. In running, it acts like a spring. It also absorbs energy when the foot strikes the ground and releases it during the toe off phase of propulsion. We've got jumping. It loads up during the crouch and fires explosively during takeoff, providing a huge boost to vertical jump for explosive movements. We've got power output in sprinting, cutting, jumping, lifting. The Achilles amplifies that muscular force, creating a rapid, powerful transfer of energy from the legs to the ground. So it's not just like a passive rope of tendon that's there. It's an energy storage and return system. So it kind of acts like a rubber band, stretching under load and snapping back to release stored energy, which boosts speed and efficiency. So it's a vital aspect, not only with walking, but like running, power output, athletes, it's everything. The effect of Achilles tendon tear to the foot and the other surrounding tendons and nerves. So I wanted to touch on this point a little bit because after tearing my Achilles tendon, I just feel like my foot, the bottom of my foot and the top of my foot and my toes just feel like really funny, kind of numb still, and I just can't like use them like before. So I just kind of wanted to talk about like the impact that tearing your Achilles tendon has on the other possible tendons in the area or nerve tissue. So when you tear your Achilles tendon, you lose plantar flexion strength. So basically you lose the ability to strongly push off with your foot, especially when you're walking, running, or jumping. So you won't be able to even rise onto your toe. You have changes in your foot mechanics and gait. Without your Achilles functioning properly, the gait becomes flat-footed, so the person can't properly push off the ball of their foot. The body often compensates by overusing smaller foot muscles and shifting more weight to the other tendons, which can cause strain on those tendons. Specifically, the posterior tibialis tendon, which helps support the arch of the foot, it also gets way more stress when you tear your Achilles. This can lead to problems like fallen arches or posterior tibial tendon dysfunction if that stress isn't corrected. You also can get increased stress load on the flexor hallucis longus tendon, the flexor digitorum longus, and the posterior tibialis tendon, as well as the plantar fascia. These can all become overloaded just from overcompensated because they're basically picking up the slack from your Achilles tendon not functioning. Typically, after you tear your Achilles, the flexor hallucis longus tendon hypertrophies, meaning it grows larger because it is taking on more of the stress load. This can kind of lead to secondary injuries like tendonitis or plantar fasciitis over time. So just important to know, like, if you do go through that experience, just thinking about those other tendons as well. I know the main focus is going to be trying to recover the Achilles tendon, but we also want to make sure we're de-stressing those other tendons and just trying to get everything back to an even gait. All right, so what nerve impacts does tearing your Achilles have? So basically, when you tear the Achilles, you have more swelling and inflammation, just like with any injury, and that's what can irritate any nerves that are nearby. Specifically, the sural nerve, it can become irritated. It can get numbness, tingling, burning on like the outside of your foot and your ankle. Sometimes swelling can also affect your tibial nerve, kind of causing symptoms on the sole of the foot. So in conclusion, the bottom of foot tendons are basically overloaded when you tear your Achilles tendon. And they're not built for the massive loads like your Achilles is, so they often become strained or injured if rehabilitation doesn't carefully address the imbalance. Next, we're going to discuss what causes an Achilles tendon to rupture, and are there any like risk factors that contribute to it getting torn. So usually what happens when an Achilles tendon ruptures is sudden high stress placed on the tendon, especially if the tendon's already weakened or overloaded. Most ruptures are a combination of a weakened tendon plus a sudden forceful movement. Usually it's not just like a bad luck thing. The tendon's been slightly degenerating for some time. For me personally, I've always like been athletic and I've never really sustained an injury, but I have been coming back from a heart issue. So basically that week that I tore my Achilles tendon, I had been doing a sudden increase of running, and I could really feel all of my ankle muscles and tendons were really tight. And then I went and played basketball, and I think I just completely overloaded the tendon, and so that's why I think mine tore. So sudden forceful movements, changing direction quickly, chronic tendon degeneration or tendinopathy. External trauma can sometimes cause it. If you get a direct hit to the back of your ankle, that can cause your Achilles tendon to rupture. So there's a couple of risk factors that weaken the tendon. Age is one. The most common is 30 to 50-year-olds. If you have previous tendinopathy or tendon pain, poor flexibility or tight calf muscles, corticosteroid injections in or around the tendon, fluoroquinolone antibiotics. It's rare, but there has been a few studies that have linked those antibiotics specifically to Achilles tendon rupture. High BMI or obesity, if you have a poor warm-up or fatigue during activity. My surgeon told me that 60% of tears are caused from basketball specifically. Another risk factor is genetics. Certain genetic variations affect how strong and organized your collagen fibers are. So some people naturally just produce weaker, less organized collagen, making their tendons more prone to microdamage and rupture over time. So sometimes there are like microscopic changes happening to your tendon that happen before that rupture. So in a healthy tendon structure, you have your type 1 collagen fibers. They're tightly packed and aligned parallelly. They act like a high tension cable. They're strong, flexible, built to transmit huge forces. If you've got tendinosis or chronic degeneration, over time with repetitive stress, poor healing, the collagen fibers basically just lose their organized alignment and they become like crimped or out of order, out of alignment, and they thicken irregularly, so they're not healthy in a long way, and this can cause micro tears. This can also make the blood flow in that midsection even worse. You've got your tendon cells, which are called tenocytes. They just start producing weaker, less organized collagen and more ground substance, which is like the jelly-like material that surrounds the collagen fibers. So this leads to the tendon just getting softer and less elastic, increasing the rupture potential. So when you do have a rupture during an acute event, or like when an explosive force is applied, like when you sprint, jump, the weakened, disorganized collagen fibers basically just can't handle the sudden load, and the tendon tears in like a frayed rope like pattern. So the fibers snap unevenly. Microscopically, the rupture looks like torn spaghetti under a microscope. It's not clean cut. What happens after that, the surrounding inflammatory cells rush in and they try to start the repair process. So usually, just kind of to summarize, an Achilles rupture doesn't usually happen to a perfect tendon. It happens to a compromised degenerating tendon that's been kind of failing for some time, or just over fatigued. So what happens immediately after you rupture the Achilles tendon? So first you've got the neutrophils that rush in. They're the first responders. They clear out the debris, i.e. the dead cells, the damaged collagen, by releasing enzymes and reactive oxygen species. And then we've got the monocytes, which become macrophages. But the monocytes, they move in quickly after the neutrophils and turn into macrophages, which means they basically are eating the dead cells and the tissue debris through phagocytosis, and they help coordinate the healing by cleaning it up. Then you've got the mast cells, which release histamine and other chemicals that increase blood flow and make the local area more leaky, bringing in more immune cells. So after that, you've got usually around the proliferative phase, which is days 7 to 21. You have the M2 type of macrophage that comes into the pro-healing role, and they release growth factors to stimulate the tendon cell, the tenocyte repair, and high blood vessel growth with angiogenesis. Then you've got the T lymphocytes, or the T cells, and they just help regulate the balance of the inflammation process so that there's not too much inflammation and repairing and preventing the repair process. And then you've got the fibroblasts and more tenocytes coming in. So these guys are not immune cells, but they're very important because they start producing the new collagen to actually rebuild the tendon. So just kind of a simplified timeline. Right after you rupture your Achilles tendon, within the first hours, you've got the neutrophils. They come in and clean everything up. Within the first few days, you've got the monocytes, which go into macrophages. They arrive and they start coordinating tissue cleanup and repair. And then from the first week and on, you have the macrophages that shift to become more of a healing. The fibroblasts and the tenocytes start to rebuild the collagen of the tendon. So bottom line, it's a highly coordinated immune response first, and then you've got all these different cells coming in to clean up the area up and then start regenerating the collagen fibers themselves. Okay, so there's a couple of different types of ruptures. You have a full rupture and a partial rupture of the Achilles tendon. So a full rupture is basically just a complete tear. There's a gap between the upper and the lower part of your Achilles tendon. This is the most common. It's really rare to have a partial tear. And actually, my surgeon, who has been doing this for, I think he said like 30 plus years, he teaches at the University of Utah. So he goes through a lot of these surgeries, and he said that he's like, it's super rare to have a partial rupture, and he like very rarely comes across it. But with a full rupture, you completely lose plantar flexion, and you can't push off the ground with your toe. Usually there's like a sudden pop or like a snap feeling when it happens, with some bruising, and you're unable to walk properly. And usually the recommendation is surgery. There's a couple of recommendations to do non-surgical, which we'll go over. With a partial rupture, only part of the tendon is torn, and there's still part of it partially intact. So you still have some plantar flexion, but it's weak and painful. With a partial rupture, obviously it's not as painful. There's a partial gap in the tendon. We've still got some localized fiber disruption and attachment. But usually they can manage the partial rupture with non-surgical intervention. So, common cause for a partial rupture is chronic degeneration or tendinosis, sudden stretch or too much load, repetitive overuse, explosive force. The tendon could have been weakened by age, degeneration, or past micro tears. For full rupture, common causes are poor warm-up, fatigue, unexpected force, certain antibiotics or steroids that can just kind of basically weaken the tendon. Okay, so there's a couple of different repair techniques. I'm just going to go over non-surgical and surgical. But the non-surgical route, basically you just immobilize the foot and the ankle in the plantar flexion position. So you're basically pointing your toe down and bringing your heel up closer. So if it brings the two torn ends of the tendon closer together. And basically from that, your body sends out signals to regrow the collagen and just reattach the two ends, which is pretty amazing. With that, you still do physical therapy. You're still in a boot for months. And it still is like a long process. So the indication for non-surgical is usually if you have like small or partial tears of the Achilles tendon, if you have patients who are less active or older or at a high surgical risk, or people who just don't want to do the surgery. The pros to non-surgical is, there's no surgical risks with infection, wound problems, or nerve injury. Cons, there's a slightly higher chance of re-rupture compared to if you were to do the surgical route. There's a longer rehabilitation time if you don't do surgery, and you'll likely have less tendon strength compared to surgical intervention. So if you decide to do the surgical route, what they do is there's a lot of different methods to doing this, but basically the surgeon will make an incision on the backside of your leg, and they'll go in and grab the two ends of the Achilles tendon and overlap them slightly and just suture them together. Sometimes they have to do like a tendon augmentation or a graft if there's like really severe cases. The indications for surgical intervention are if you have the complete tear, high performance athletes, people just wanting to return to high level sports quicker. And the pros with that is you have a lower re-rupture rate, usually about 2 to 5% compared to like the older conservative treatments. Usually you have better strength and recovery and an earlier return to sports, and it's a direct restoration of the tendon. The cons, you do have that risk of infection because of the surgical incision. You have the potential for wound healing issues and nerve injury, especially to the sural nerve. And there is the risk of surgical complications, anytime that you go under general anesthesia. I personally chose to do the surgical route because I wanted my tendon to be strong and able to recover and do like a high power output with athletics, specifically CrossFit. Okay, so after you do surgery or non-surgery, you still have got to go through the post-operative rehabilitation process. All in all, it can take about 12 months for full recovery. So phase 1, immediate post-op protection, weeks 0 to 2. The goals here are in the first 2 weeks are to protect the surgical repair, to control the pain and the swelling, and to prevent stiffness in the other joints. The treatment is to do no weight bearing with crutches, immobilization in like a boot or a cast with your foot in the plantar flexion position, so toe down. And then you want to elevate the leg and apply ice regularly and just kind of gentle movements of your toes, knee, and hips. For phase 2 of the post-op rehabilitation, this is going to be weeks 2 through 6. This is where we start to incorporate controlled movement and just partial weight bearing. So the goals with that is going to be to begin gradual ankle motion without overstressing the tendon, and you want to initiate weight bearing really carefully. The treatment is to transition into a walking boot with heel lifts, so you can maintain that plantar flexion position. You start with partial weight bearing and eventually progress to full weight bearing as tolerated. And then you've got the gentle, passive, and active ankle range of motion movements that you want to do, especially plantar flexion and neutral dorsiflexion. But you do not want to go forced dorsiflexion, which basically means you don't want to point your toe back up towards your knee in a forceful way, because that can stretch out the Achilles tendon and cause it to become weakened. And it can increase your chance of re-rupture. And then throughout this time, you also want to incorporate some isometric calf activation with the gastrocnemius and the soleus muscles, because by this point, they likely haven't been being used like whatsoever. So you're going to start to get some muscle degeneration. And then you've got phase 3, which is the strengthening phase, weeks 6 through 12. And the goals here are to restore full ankle motion and to begin rebuilding calf strength. So what you're going to do is remove the heel lifts that were in your boot just gradually, one at a time. And you're going to do range of motion exercises like putting your foot in the plantar flexion, the dorsiflexion, inversion, and eversion positions. And then in this phase, you're going to begin resistance exercises like with a TheraBand. And then like some stabilizing proprioceptive training to kind of help incorporate all the other little tendons and muscles surrounding that Achilles tendon. Another thing that you can incorporate in this phase is the stationary bike or swimming if your incision is healed. And then we've got months 3 to 6, which is where we start to incorporate more advanced like strength and functional training. So in this phase, we really want to build the calf muscle endurance and power and restore the dynamic ankle stability. So usually they'll do like eccentric calf raises, some light jogging progression, plyometric exercises like jumping or hopping, and then like sport specific drills, cutting, agility. Then we've got phase 5, which is months 6 to 12, and this is where you can start returning to sport. Generally speaking, everybody's body recovers a little bit differently, but this is just kind of the general guidelines. So the goals during months 6 to 12 is to achieve full strength, speed, and explosive ability and prevent re-injury. So usually the treatment for this is like full sprinting, sharp changes of direction, jumping, gradual reintroduction to like competitive level training. You want to monitor your calf strength, symmetry, aim for at least 90-95% compared to the other side that's not injured. So just trying to kind of rebalance everything back out. So just kind of some important key points of the Achilles rehab. If you can do early functional mobilization, that improves your outcome. So movement is medicine. You want to immobilize it for a few weeks, but then after that you want to move it. Controlled loading of your tendon stimulates better tendon healing. It stimulates blood flow. It stimulates the collagen fibers to continue to rebuild and strengthen that tendon. And you want to avoid aggressive dorsiflexion stretching too early to prevent elongation of that tendon. So what is the physiology of the Achilles tendon? How is it healing? So there's 3 kind of overlapping biological phases. You've got inflammation, proliferation, and remodeling. So the inflammation phase is days 0 to 7. What's happening during this phase? So immediately after you injure, the torn blood vessels bleed and cause a hematoma or a blood clot around the tendon ends. The inflammatory cells rush in, i.e. the neutrophils, the macrophages, and the monocytes. And these cells release cytokines and growth factors that clear away all the dead cells and debris. They recruit the tenocytes, which are the tendon cells, to the injury site, and they stimulate early collagen production. Okay, so then we've got phase 2, the proliferation phase, which is going to be weeks 1 to 4. What's happening during this phase? You've got the fibroblasts and the tenocytes that become very active, and they lay down new material. The new collagen is formed, mostly type 3 collagen at this point, which is a weaker, more immature collagen. It's just kind of laying out the groundwork. And then we've got neovascularization happening, which is where blood vessels are invading the area to deliver nutrients. And you have like a loose, kind of disorganized scar-like matrix that forms between the two tendon ends. So, I mean, at this point, the repair tissue is weak and disorganized and it can't handle strong loads. So that's why the foot is immobilized for this time. And then we've got the remodeling phase, which is going to be weeks 4 to 12 and on, even up to a year. So what's happening during the remodeling phase? Type 3 collagen is starting to be replaced by the stronger type 1 collagen. The collagen fibers are reorganizing along the lines of the mechanical stress, so based on how the tendon is loaded during rehab. The tendon tissues become stronger, denser, and more aligned, and the cellularity decreases, meaning the tendon becomes less swollen and more like normal tissue. So controlled loading during the physical therapy exercises during this phase is critical because the mechanical stress helps the fibers align properly. So they're not just like a jumbled mess. It's one long paralleled collagen tendon. Okay, so another question that I had throughout all of this, are there any supplements that can help aid in the healing process of my Achilles tendon? So there's some varying opinions about this topic, but there is some research out there supporting a couple of supplements. So there's collagen peptides, vitamin C, and omega-3 fatty acids, and gelatin. For the collagen peptides, I mean, basically your tendon is collagen, so consuming collagen peptides is going to help provide the amino acids that are essential for building new collagen fibers. The research that goes hand in hand with this typically is showing that the collagen supplementation has to go hand in hand with the mechanical loading or like the rehab exercising that you're doing. So they recommend 10 to 15 grams of hydrolyzed collagen 30 to 60 minutes before rehab to stimulate the healing. Another supplement that's got some research behind it is vitamin C. And what this one can do is basically, it's an essential cofactor for collagen cross-linking, which is making the collagen fibers stronger and more organized. So if you're supplementing vitamin C, it may enhance like early tendon repair. The dose that's recommended is 500 to 1,000 milligrams per day. Another supplement is omega-3 fatty acids, aka fish oil. And what this is going to do is reduce chronic inflammation that could impair the healing process. The omega-3 could also help modulate the inflammatory response during the early healing phase. There are some studies out there that are animal studies suggesting that omega-3s improve collagen fiber organization. The recommendation is 2 to 3 grams per day. And the other supplement is gelatin. So gelatin is similar to collagen in the sense that it's rich in glycine and proline. There's some evidence out there that suggests the gelatin plus the vitamin C together right before you exercise can spike the collagen synthesis rates. So like with any of these supplements that you might want to try, it sounds like taking them 30 to 60 minutes before you stimulate the blood flow and the muscle contraction to the area with exercise is what's really going to be the benefit with these. So is there anything that can inhibit the repair and the healing process of a torn Achilles tendon? Well, poor blood supply, of course. This reduces the oxygen and the nutrient delivery to the tendon. Excessive inflammation, this will prolong the healing process and lead to more scar tissue formation. If you have too much mechanical overload too early, this increases the risk of re-rupture or tendon elongation, which leads to a weaker Achilles tendon. You can have mechanical underloading, which is basically just immobilization for too long, and this is going to increase the risk for like a more weak, more disorganized collagen matrix. Another thing that can inhibit repair is infection. There's systemic conditions that can inhibit repair, like diabetes, smoking, obesity. Diabetes is going to impair the fibroblasts and the collagen activity. Smoking or nicotine is going to decrease blood flow, oxygenation, therefore decreasing the healing. Obesity is going to increase the mechanical load on the tendon. And then there's a couple of medications that can also inhibit the healing process. We've got corticosteroids, antibiotics, and long-term use of NSAIDs. So are there any complications and outcomes to this? Well, we've got the complication of a re-rupture. The repaired tendon could possibly tear again. Usually this would happen within the first 6 to 12 months if it's overloaded too early. The re-rupture rate is usually about 2 to 8%, like with their modern surgical techniques. So it's pretty low, but it does happen. Another complication is infection. Surgical site infections occur in about 2 to 4% of Achilles tendon surgeries. Deep infections can threaten the tendon and surrounding tissue. Wound healing problems, you can have delayed healing if you have like thin skin or poor blood supply over the wound. You can also have wound reopening that could happen. This is especially common like in smokers or diabetic patients or obese patients. You also have complications with nerve injury. Sometimes the sural nerve, which is the one that runs right next to the Achilles tendon, can be injured during surgery. This can cause numbness, tingling, pain. You can have tendon elongation. If the repaired tendon stretches too much during the healing process, then it will just become too long. And this can lead to like a weak push-off strength. You've got scar tissue formation that can happen. Basically, just excessive scar tissue causes the tendon to stick to surrounding tissues, and this limits the ankle range of motion and cause like stiffness and weakness. We've got calf muscle weakness and atrophy. This is caused because of prolonged immobilization of the foot and a reduced use of the calf muscles, the gastrocnemius and the soleus. Regaining the full calf strength often takes 9 to 12 months. And then another complication that could potentially happen is just deep vein thrombosis. This is a blood clot. So this is because after surgery, usually people are less mobile, and so this increases the risk of a blood clot developing. Specifically with the Achilles tendon because it's such a large tendon. Because of this, some surgeons will put the patients on blood thinning medication. Okay, so that's the more anatomical side of the Achilles tendon, the rupture, the healing process, all of that. I have a friend that recently went through an Achilles tendon rupture as well, and I wanted to dive a little bit into his thoughts with the process. So I asked him a few questions, and I'm just going to go through those with you to kind of give a different perspective. So how did tearing your Achilles change your approach to training mentally? So my friend's name is Dallin. He trains CrossFit. He coaches CrossFit. He's a very active individual. So how did tearing his Achilles change his approach to training mentally? He said, I've always been of the mentality that when you're injured, it shouldn't stop you from training. You just need to figure out a new way. Blood flow is one of the best catalysts for healing, and I've also had friends who suffered the same injury and became really depressed because they were too stagnant. I feel like this injury deepened my resolve to train. My drive to train and eat right has increased. I would totally agree with Dallin in the sense where my drive to train and eat right has increased. It's pretty frustrating when you feel like you're not able to work out or do anything in the way that you want to do or that you're used to doing. And so it kind of makes you mad and refocuses the energy to like wanting to work out even more and eat even healthier. Okay, so I also asked him, what has been the hardest part of your recovery and how have you stayed motivated during this time? He said, I felt like a burden to those around me. At the gym, I often couldn't get equipment out myself and needed others to do it. If I needed to change weight mid-workout, I had to ask someone else for help. Has your injury taught you anything about yourself that you might not have learned otherwise? He said, I've learned that I can inspire people. I've tried for years to get friends to join me at the gym. I've always told them that CrossFit is literally for anyone. It wasn't until I started recording my workouts and posting them on social media that they believed me. Since then, several friends have joined me at the gym. In the moments when it felt like you might not make it back, what has kept you going? I never really felt that way. Over the years, I feel like I've become very patient with myself. I understood that this would take time and that I needed to take it one day at a time. Figuring out how to modify my program workouts each day kept me engaged and excited to work out. I also set a goal to complete my workouts as close to prescribed as possible. It became a challenge to see how many burpees I could do with one leg or how many wall walks I could manage with one leg. Have you discovered any new training methods or tools during recovery that you'll keep using long term? ChatGPT is great for training. I'll also never underestimate the value of my legs again. I yearn for leg soreness. I can't wait until I can fully train legs again. What would you say to your pre-injury self knowing what you know now? He said, don't undervalue your legs. Don't slacken training. One day you may not be able to. Do you think this injury might open new doors for you personally or professionally? I hope so, he said. I really love CrossFit and I love training and helping others train. I just never felt like it was a practical way to provide for a family. I'd love it if I could eventually translate it into a profession, but time will tell. For now, my goal is to work out consistently and post my skilled workouts on social media consistently. We'll see if it goes anywhere. So thank you, Dallin, for sharing your thoughts and your perspective. Going through an Achilles tendon rupture is not the funnest thing, but I hope that this podcast has kind of given some insight and some helpful tips.